This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.
Hello, my name is Dr. Rob Page and welcome to Doc Talk. Doc Talk is a podcast that is produced by the Knoxville Academy of Medicine and features its physician members, providing information for patients which are helpful in their day-to-day life and in terms of making their healthcare decisions. And I'm very pleased to have with me today Dr. Matt Mancini. Dr. Mancini is a general surgeon who works with university surgeons here in Knoxville.
That's correct. Yep.
Welcome.
Well, thanks for having me. I appreciate it.
Thank you for being here. And you're here to talk about something really interesting because it was not something that was around when I was in my training, and something I have very little exposure to, but it's something that is really on the cutting edge. And we're going to talk about robotic surgery.
That's correct. That's correct.
So I always anticipate that when I think about robotic surgery, that the surgeon is basically sitting in the other room having a cup of coffee and there's a robot who's doing the surgery.
Yeah.
But that's not it at all, is it?
Well, I always kind of, think about back to the science fiction films that we grew up with, where the robot would always malfunction and the arms would be going this direction and everything. So yeah, there is a lot of misconception about what robotic surgery is. But robotic surgery today is basically creating a minimally invasive approach to a lot of different abdominal procedures that basically gives us, I would say, a little bit extra assistance. So it's still us performing the operation. We're in the room, we're next to the patient, but rather than standing our arms extended over the patient, we're sitting comfortably at basically a desk next to the patient and performing the procedure with assistance. So a device that basically allows our hands or our fingers to basically articulate and give us more directionality, a little bit more fidelity, as well as our eyes get older, a little bit more depth and accuracy.
Gotcha.
In the procedures that we offer.
So intrinsically, it's not. So you're still performing the surgery, but the robot assists you in terms of maybe eliminating any wasted motions. Helps you in terms of being able to reach or maybe curve your hands in ways that you normally wouldn't. Limiting the amount of motion and essentially limiting the amount of cutting or surgery that you're doing on the patient, and therefore probably decreasing the recovery time and the healing time for the patient.
I think if we approach things minimally invasively and we're using small incisions and trying to decrease the trauma to the patient's abdomen, whether it's a straight stick laparoscopy versus a robotic assistance, I still think I go back and forth. Yeah. I haven't gone exclusively one way or the other. I know there are some specialties, GYN oncology and some urologists that just say, I can't operate with straight instruments anymore. And I still think there's plenty of applications for that. But I think what robotics does, as you mentioned, range of motion, allowing to get into difficult places that maybe a laparoscopic approach can't get, especially when we're at kind of the ends of our instruments. And, our patients aren't getting any thinner. They're not getting, and so it allows us to get to tougher corners, tighter areas, further distances, whether we're low in the pelvic area or we're high in the chest. It just gives us that ability to get to places that we couldn't necessarily get with the straight stick laparoscopy.
So the types of surgery that you perform robotically are all within the abdomen.
90%. I mean, theoretically, we can get up into the chest and assist, like the thoracic surgeons, to do some type of esophageal surgery. But 90% of what I do is basically from diaphragm to pelvis.
So I'm a patient, and I know that I'm supposed to. I know that I have been referred for surgery of my abdomen of some sort. What types of surgery do you generally perform robotically assisted? What are the most common types?
Right. So a lot of it is just patient's body habitus and the procedures that we're offering. So I may see a person like today. I saw a guy with just a straightforward little belly button hernia. But I look at his abdomen and he's got a lot of separation in his rectus muscles. And I say, well, we can either do an open procedure where we make a little incision, put a patch in. I can do a laparoscopic where I can put in a larger patch, or I can do a robotic procedure where I can actually sew the muscles back together and try and bring that abdominal contour back together. That wasn't something that was possible 5 years ago.
Wow. And you're actually doing this without, so 5 years ago, you would have to have made an incision all the way down the abdomen.
Right.
And basically go in. And when you talk about sewing the rectus muscles together, you're talking about the abdominal muscles, which had separated. And so, but you were actually able to do it from the inside.
Correct.
As opposed to making a large incision and doing it from the outside.
Right. Basically, 3 small incisions gives you access to the abdominal musculature, and you can go from doing a tiny umbilical hernia to doing a very complex abdominal reconstruction. I'm not quite to that point yet. I think there's an evolution, but those things are happening nationally where they're doing very complicated, advanced abdominal wall reconstruction with the robot.
Wow. So, the surgery you mentioned today, you talked about a hernia repair. Different types of hernia. Is there? We know about hernia being basically sort of a hole in our abdomen.
Correct.
Are there types of hernias that can be repaired? Are there types that can't? What are the best types to approach with robotic surgery? And what are the most common types of hernias that you treat?
Right. So when I first, started using the robot, it was about 2013. So it's been about 7 or 8 years, and you had some limitations into technology. The robots were still kind of clunky. You may not have access to the robot, so you would kind of just pick and choose certain procedures that you thought would be optimal. But now we have much narrower robots, much more access to them. And an inguinal hernia that 2 years ago I would have said I would never have fixed robotically. Now I look at a patient and I say, well, based on your height, your waist, where the hernia is, this may be better robotically. And I've just been amazed at how much less swelling, how much less discomfort the patient has, even from a laparoscopic procedure. I did not expect to see that. And patients come in and they say, that was the easiest thing I've ever done.
Wow. So as opposed to what would have been several years ago, a very involved surgery with quite a bit of recuperation, this is something that we talk about. Inguinal hernias, the ones that happen down here in our, around our,
groin area.
Groin area. I was going for groin. So ones that happen in the groin area, which in earlier days, we would have talked about, a fairly, more extensive surgical procedure, a lot of recovery time.
Yes.
Now, not so much.
Right. Yeah. I mean, I saw a young man last week, and his hernia went all the way down to the bottom of his scrotum. And I said, this could be a very big swelling, depending on how it's done. And I did it robotically. It takes almost less time, and he had much less swelling and pain than I would have expected, as big as this hernia was.
Wow, that's incredible. So now we talked about hernias. What other sorts of surgical procedures do you approach robotically?
So again, I do probably about 50% of my gallbladders now robotically, mainly because, again, patient size, body habitus, BMI, if they're above a 30 or 35 BMI. I think with the larger liver, it gives me ability to lift the liver safely. Foregut operations, hiatal hernia work. We're starting to do bariatrics that way. I know there's other places in town that are doing it, but I think it's just something that, again, it's an evolution. And as we develop more and more procedures, it just gives more access to what we can do on it.
Well, now you mentioned the advantages of being able to do this robotic surgery from a surgical standpoint. What are the advantages to me as a patient? Why would I benefit from having, you mentioned a little bit about the recovery time, but why would it benefit me? What type of patient are you generally looking for that you want to see and do this robotically to help out? Basically looking at it from the perspective of the patient.
I often tell patients, for you, the operation may not look any different than a laparoscopic procedure. The incisions may be similar. The recovery may be similar. But I know, because I can tell and know more than they're seeing outside, that this may be much easier and be easier and quicker if I offer it to them robotically. I still don't tell them that's the only way to go. I still say there's 3 or 4 different options on how we can approach your process. But I know just basically seeing their anatomy and their body habitus and where I'm going to put my incisions may make it a lot easier for them and for me. And there's a real ergonomic benefit to this. I mean, I'm a little selfish. I mean, I can't keep my arms like this for 7 hours a day, and my eyes get strained and my neck gets fatigued. So I can do 3 or 4 robotic procedures and at the end of the day feel like I hadn't really done much because I'm not lifting things anymore. I'm using, the robot does all the heavy lifting. I'm just doing the fine tuning.
And not having a fatigue surgeon is generally, I would say, definitely a benefit to the patient as well. In terms of,
I would hope so.
Yeah. So let's say I'm a patient and I know that I need to have some form of intra-abdominal surgical procedure done, be it a hiatal hernia you mentioned, an abdominal hernia, that perhaps that I need to have my gallbladder removed. And I'm interested in perhaps, approaching this to, maybe I should go get, because of the benefits thereof, robotic surgery. Is this something that my insurance would pay for? Is it something that I have to, do I have to do any extra studies or tests before I know that I can do this? And are there situations in which I just wouldn't be a candidate?
Yeah, that's all great questions. There really aren't specific codes, and codes are what the billers and the insurance companies use to create that awful bill that you get after you have a procedure. And hospitals realize that there's a laparoscopic code, but not a robotic code. So they probably will use the laparoscopic code. And the hospital realizes, yes, you're utilizing a robot, but we can't pass that cost on to the consumer. So the hospitals really provide the service, and the patients don't need to do anything other than just know as much information about their surgeon and make sure that their surgeon's competent and has had done this multiple times and has gone through proper proctoring and has the technology and the training and that sort of thing to decide.
And that would be your practice, which is at University Surgeons, which is at UT.
Yes.
Now, this is something that insurance would pay for. How about, if we're talking about doing a gallbladder surgery with just routine laparoscopic, which essentially is just going in the abdomen without a robot, versus robotic surgery, what would the advantage in that situation be for me?
Again, I think, there is some thought that the instruments are less traumatic to the abdominal wall. And allowing us to articulate our instruments inside the patient hopefully will cause less trauma to the abdominal wall.
Gotcha. And therefore,
basically recovery, less
decrease
discomfort.
recovery time and increased. So, well, let's talk about your practice and say we sort of know some of the procedures that you can do there. Where's your practice located? How would I get in touch with you? Is there any way that I can get any additional information about the types of surgeries that you perform?
Yes. I practice at UT Hospital, but I have an outreach clinic in Sevierville, so I do go up there to our university office up there. But our website, utsurgery.com, has lots of information. We were working on it and trying to update it, and that will give information about robotics, as well as Intuitive Surgical. If you go to Intuitive Surgical, that's the company that does the main robot that I use. They keep my statistics.
We'll put all this information down at the bottom of the screen for the patients.
That'll be perfect.
So the website, would that have information about the types of surgery as
Yes.
well as you have worked with other physicians as well who
That's
do
correct.
perform this surgery?
That's right.
And so if I'm a patient, if I'm up in Morristown, I don't necessarily would necessarily have to come all the way to Knoxville to have my surgery. I could actually just go to Sevierville and have it done.
We don't do those surgeries up there, but
okay.
but I do have an outreach clinic up there. So
I could come see you as a patient
Yes.
in clinic
Yes.
and then eventually have my surgery down in Knoxville.
when
Gotcha.
robotics first came out, they were, having this platform where, a surgeon in New York could sit at a console and perform a surgery across the ocean in London. That has happened.
Wow.
But that's not very common. that's kind of an oddity.
I was going to say, and considering as you say, the fidelity of the internet these days, I'm not sure that's something I would want to have done per se. It's much better having you there. So, Dr. Mancini, thank you so very much for joining me here today and giving us some good information about robotic surgery, telling us what the advantages of it are, sort of decreasing some of that, increasing our knowledge and decreasing some of the stress level about how it's done, that it really is a controlled environment with the surgeon, and it's not something that we think about as more of an automated type procedure, and giving us information about your clinic so that we can come and see you as a patient and basically have if we need to have something done, can have it done with you.
I appreciate it.
So, and with that concludes this episode of Doc Talk. Doc Talk is a podcast that is produced by the Knoxville Academy of Medicine and features its physician members giving information to patients that are helpful in terms of making their healthcare decisions. I'm Dr. Rob Page. Thank you so much.
This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.